Hello everyone. Now I'll discuss question of ophthalmology. So we have a 52-year-old lady who comes to her general practitioner with recurrent headache. She refers her to you in emergency, seeing the fundus appearance given below. What are the most likely diagnosis? Very simple question, no more detail given. What the examiner expects from you is you should know what are the fundus finding given. No other history is given. Okay. The answer to this question is hypertensive retinopathy. Well, in this we are getting grade stage 3 type of retinopathy, and it is undiagnosed hypertension. In the question, examiner has not even declared that patient is hypertensive. Well, but it is stage 3. What is stage 3? For that you got to know all the stages. So there are stages, stage 1 to 4, hypertensive retinopathy. Let's learn the basic. Stage 1, focal or diffuse thinning of the arteriole related to venules. That means you can say there is arteriolar constriction is the feature. That means the patient has hypertension. Stage 2, more narrowing, okay, and vessel with wide light reflex can exhibit so-called copper wiring. And later on the vessel become fibrotic, the light reflex become a thin white strip, what you call as silver wiring. And later on, continued thickening of the arteriolar causes indentation of venule in common adventitious AV sheet, what we know as AV nipping. Okay, well, it is getting fibrous. That means that as far as lumen is concerned, is more and more reduced, but now it is going into fibrotic type of picture, right? So that is going to give a little appearance of so-called AV nipping. Stage 3, we start getting cotton wool spot, exudate and hemorrhage. And stage 4, now that there is optic disc is swollen, and that is so-called papilledema, okay, so-called malignant hypertension. Right, sir. But now I have got some questions for you. That stage 1 and 2 are similar to arteriosclerosis of aging. Stage 3 and 4 are medical emergencies. Patient, we should take a special care, otherwise patient might lose the eyesight. Well, you can see this is the typical AV nipping. Okay. Arteriole are narrow and there is decreased AV ratio because arteriole are getting narrowed down. Because of what? With the constriction, they are narrower as compared to vein. Look into this also. Vein is broad, arteriole are, so AV nipping what they classically call as. Okay. Papilledema, swelling of the optic disc is there. Hemorrhage and cotton wool, copper wiring is there. Look into this. Looks like a copper wire. Okay. Cotton wool spots are there. Hemorrhage is there. Now I have some question for you. Cotton wool is due to what reason and why exudates are there? What's the reason for that? Stop the video, write down the answer. Well, first we can see the hemorrhage. Look into this picture. Lovely picture is there. You can see hemorrhage are there. You can closer look into this. Bleeding is there. Much clear picture to you with the arrow marking. This is hemorrhage, bleeding. B is exudate. Look into this. Into this picture, exudate are there. What is this? Look into closer look. they are fatty deposits. And finally, we look into C, this one. This is the cotton wool. They are microstroke, or we can say they are microinfarct. Microinfarct are cotton wool. Okay. So with this background, let's look into more pictures. Arterial narrowing, AV nicking or AV nipping also. Then the stage 3 where we are getting hard exudate, hemorrhage and cotton wool, and finally we are getting papilledema, and in the optic disc is swelling. And how do you really say? Because there is a blurring of the margin, margin of the optic disc. It's not a clear, because the disc is swollen now. That in this also you can't see a clear lining of these, of boundary of the optic disc. Okay, this is stage 4. One more lovely picture: cotton wool spots, retinal hemorrhage, papilledema, AV nipping, hard exudate, and silver lining, everything at one place only for a better visibility. Well, let's look into other option. Retinitis pigmentosa is a visual failure rather than the headache. Now, what is retinitis pigmentosa? Again, stop the video, write down the answer. Well, it's a genetic disorder. That means the family history will be positive and the patient will be having problem right from the early childhood. This loss of vision is there. Our patient presented with headache, not with much of the vision loss. Symptoms include trouble seeing at night and decreased peripheral vision, so-called sight vision is not there. For example, suppose this is the field what is visible. The patient will be able to see this much only, he will not be able to see. He will not be able to see. This is so-called tunnel vision is there. Okay, the word we use is tunnel vision. Vision will be there. He will not be able to see periphery. And complete blindness is usually uncommon. And one more important feature is that, again, repeating second time, difficulty at night. Why? Again, stop the video, write down the answer, why the patient has difficulty in watching at night. Okay. Well, I hope you have written the answer in your copy. Very well. It's basic physiology. When we go from light to dark, our pupil dilate. Pupil dilate, now our vision area is increased. But in this, definitely pupil will dilate. The problem is not in the pupil, but they will not be able to utilize the peripheral field. That's why their vision doesn't improve at night. So, and they are more problem in the night, so-called difficulty in night vision is the classical feature. And just to inform you, same thing happen in vitamin A deficiency also. Now this normal vision, somebody is going on the road, lovely scene is there, you can say lovely scene is there. This is normal, but it's seen by a normal person. But suppose in the car, it is one patient sitting and he has retinitis pigmentosa. What he can see, he will be able to see only this much. If I have to draw again, so he's only seeing this much. Rest periphery field he is not able to see. Okay, this is the classical tunnel vision. You can see, you can compare the two pictures you can compare. He can see only this much. This is not visible to him. Well, same. He is seeing only this much. A normal person will see the entire picture, but he can see only. Well, now look into my vision. This is tunnel vision. You can keep your finger like this. You just close one eye. Make a small hole, and this is a classic example of tunnel vision. Otherwise, if you open, you can see the entire scene what is there in your eyes. Well, onset of symptom is usually gradual and in childhood. Our patient is an elderly lady. What is the underlying mechanism for retinitis pigmentosa? This is loss of rods, and later on in the cones also. Okay, the loss of rods and cones, which are so-called meant for pigment cells. Diagnosis by examination of the retina, finding dark pigment deposit. Well, other things are electroretinogram, visual field testing will get tunnel field, and genetic testing. Currently, there is no cure for retinitis pigmentosa. Now, this is the classical picture. You can see all the black spots. This is normal fundus, and this is the beautiful picture of fundus. Retinitis pigmentosa, all black pigment in the periphery. That's why they have a difficulty in peripheral field. Optic neuritis is the one more option. It is present with a visual blurring, and there may be retrobulbar pain and discomfort. Headache is not a feature here also. Funduscopy may look normal, or there may be some nerve head swelling, but by and large, they look normal. Again, a question for you. Stop the video, write down the answer. What is the actual meaning of optic neuritis? Write down the answer in your copy. Well, it is a demyelination of the optic nerve. Okay. So you can see in this normal disc, you see the person has normal disc and you can see the beautiful car. Now the patient when has optic neuritis, there may be edematous optic disc, but at time the optic disc may be normal, but definitely blurring of the vision is a feature. Now you can compare. It's a beautiful car, red color, and now here he's not. He can see, but picture is not clear. It's the blurring of the vision is the feature. In contrast to hypertension, where headache is the main feature. And remember, in retinitis pigmentosa, it was tunnel vision was a feature. We'll talk more why this patient can have a normal optic disc also. So first of all, we learn what are the causes of optic neuritis. Multiple sclerosis is the most common cause of optic neuritis. There can be infection like Lyme, herpes, or syphilis can cause this. Autoimmune like lupus, SLE. Neurosarcoidosis, which is a multi-system disorder. Methanol poisoning, which can lead to a type of acute optic neuritis. B12 deficiency, very, very important point. Don't forget this. And finally, diabetes. Now, let's talk more about optic neuritis. Optic neuritis may be the first manifestation in around 15 to 20% of multiple sclerosis. In fact, whenever they talk about optic neuritis, usually they talk about in association with multiple sclerosis. Usually symptoms are monoocular in multiple sclerosis, something unique about, very special point about optic neuritis in multiple sclerosis. Acute onset of mononuclear painless vision loss with central scotoma. Point to be noted, it is a painless vision loss, usually acute. So that will lead to decreased acuity. But there is an additional point. Eye pain with movement, painful eye movement. So these two lines are the most confusing for the students. Whether pain is there in the eyes or no. It's a painless loss of vision. But when the patient moves the eyes, patient has pain. Well, you try like you are moving the eye right, left, up, down, normal. It's all normal. But in this patient has come with loss of vision, no problem. But now you ask the patient to move up and down. Patient will say, oh, I have pain. That means perhaps you are dealing with optic neuritis. It is retrobulbar neuritis. Why we use that need to be discussed. Well, basic concept. This is the, let's say, brain, cerebral cortex. Here is the eye, and here is the optic nerve. And we know very well it goes to the occipital lobe. We have another second eye, optic nerve. It's a very simple diagram, line diagram. And it's again going to the occipital node. We know very well it's the occipital lobe is where the area of vision is there. Well, and we also know that in this optic nerve, myelin sheath is there. Myelin sheath is there like this thing. Yeah, this normal myelin sheet is there. Now in this patient, what I told you, in one eye is a monoocular. Problem is it lead to demyelination. Okay, demyelination has happened, and okay, yeah. So this scenario has occurred. In this, myelin sheet is there. In the affected eye, demyelination is there. So now you know very well, suppose you throw a light here, this will do very fast and it reaches in the eye very fast. Why? We are well aware that in Schwann, this the myelin sheet, what we call as, these are node of Rennewehr, basic physiology, node of Rennewehr, which lead to saltatory conduction. So in this eye, the impulse will reach very fast. But now you throw a light here also, now there is no myelin sheet, it go very slowly. So there will be mismatch, the impulse coming to the occipital lobe from the two eyes. Now one more thing, it is retrobulbar because this is the optic disc from the where the optic nerve start. Problem is behind the eyes. That's why we usually call as retrobulbar optic neuritis, although the term they use is optic neuritis, but actual term should be retrobulbar optic neuritis. But this, why I'm talking so basic thing. It has a lot of meaning, which I'm going to discuss in the coming slides. Okay. So we are clear about the word retrobulbar optic neuritis. So optic nerve affected is behind the eyeball. You understood the meaning. The condition may be truly described as the patient sees nothing and doctor sees nothing. What is the meaning of that? Well, we come back to our slide again. What we just learned, the problem is behind the eye. So when the doctor is doing the fundus examination, as I told you, optic disc may be totally normal. The patient is examining, the doctor is examining the eyes, he find no abnormality in the disc, perfectly all right. But patient has difficulty in watching because his eyes are not working, his nerve is not working. So doctor sees nothing, no abnormality in the eyes, and patient sees nothing because he is having difficulty in seeing the thing because the optic nerve is damaged. I'll elaborate more about this patient. Doctor sees nothing, patient sees nothing in the coming slide. Now what patient sees, and optic disc appear normal usually, but little bit swelling may be there. Now there are few things. What is pulphoric phenomena? Write down the answer, stop the video. Now how patient sees? Look into this. Patient sees washed out color, especially red color. Now this is the normal eye. Beautiful colors are there. This is faded color. If I have to give example, you have a new cloth, maybe new shirt, colorful shirt, is looking bright, and after frequent washing it become old, it become faded colors are there. This is what is there. So this is what patient is seeing. He's not able to see the thing clearly. That's what I say. Patient sees nothing, doctor sees nothing. So color vision, washouts, petty red color is the affected most, but other colors are also affected. Now I asked you pulphoric phenomena. Well, the thing is, what I discussed was, we got two optic nerve, one with the myelin sheet. Here the impulse goes very fast. Other is the nerve without any myelin sheet. Here it will go very slowly. It means the patient is watching, maybe there is one chair is there. Patient watching by both the eyes. This will show the picture of chair very fast, and this will come slowly because the conduction velocity is slow. That means the person will be getting two images of one object. This is known as pulphoric phenomena. And there is a difference in the conduction velocity of the two eyes. This you can check by VEP, what we call as visual visual evoke phenomena, evoke potential. Evoke potential. So now you understood the meaning of what is the so-called pulfric phenomena. So how we diagnose MRI of the brain is the best way to diagnose. You can see the swelling, and this is the what we can see, comparative MRI. How we treat intravenous steroid are the mainstay, and it's an emergency, otherwise patient can lose the eyesight. Look into this. Optic neuritis is by and large, it looks normal fundus. This is the typical optic neuritis. Okay, there is an inflammation of optic neuritis. Look, damaged myelin sheet is there. Look into normal myelin sheet is there, damaged myelin sheet, and you can see the conduction velocity also. Is slow conduction velocity is there. I hope you understood that point very well. In these patient Marcus Gunn phenomena, what we call as RAPD, so-called rapid, it's a type of relative afferent pupil defect. Same thing when you are throwing a light on the eye, there is a problem in the afferent. Why? The myelin sheet is not there. So what we call a relative afferent pupil defect. Okay, this causing each to respond differently when light is shown into them. You are throwing light; both are responding differently. There is a dysfunction or disease in the optic nerve or retina, Marcus Gunn pupil, because of demyelination. Even the light response given to them, they behave differently. Let's look into other options. Diabetic retinopathy. This can also lead to severe. Okay, now this picture reveals change of hypertensive retinopathy, what we have been given in the picture. Diabetic retinopathy present with visual failure rather than the headache. Okay, so what we get in this thing, typically we can get, there may be hemorrhage, there can be micro aneurysm formation can be there, so-called dot and blot. Dot and blot are the earliest feature to appear in diabetic retinopathy. Okay, and in the advanced stages, new blood vessels are formed. This is so-called neovascularization. This is the advanced stage of the disease, and that is an emergency where we have to do the treatment in an aggressive way. Otherwise, bleeding can happen. Look into this. Typically, there is a hemorrhage is there, massive, which can lead to retinal detachment also. Now, other option is central retinal vein occlusion, CRVO. Patient comes with sudden mononuclear vision loss. Retina has congested, stormy appearance. Look into this. Okay. In retina, in all the four corners, classical feature, nerve is swollen, vein is swollen. And look into this. This is a beautiful picture. Dilated and tortuous veins, diffuse intraretinal hemorrhage in all the four quadrants. If you get this word, bleeding in all the four quadrants, cotton wool spot, is swollen disc and retinal edema is the classical picture that we are seeing here also, is so-called central retinal vein occlusion. Golden line to remember, in hypertensive retinopathy, stage 1, thinning of the arterioles, stage 2, copper wiring, silver lining, wiring and AV nipping, stage 3, cotton wool, exudate and hemorrhage, and stage 4 is malignant hypertension, so-called papilledema is the feature. Thank you very much.